Following clinical affection is based on a case I was called to where a 67-year-old female that experienced an MI due to a hypoxic event from a total airway obstruction. Mild quality CPR had begun by the bystanders, at which point, as the crew on scene, we took over the case. As CPR was in progress, we began standard procedures with the 4-lead ECG indicating that the patient was asystole. It was at this point that my mentor realized that there was no rise and fall of the chest and that there may have been a full airway obstruction. After using a laryngoscope to extract what was 3 large pieces of meat, effective CPR could continue. Backup crews and ICP crews arrived during this time, which allowed for better control administration of treatment. The patient at this point was still asystole. After treatment, which included adrenaline and intubation by the ICP, the patient had ROSC with tachycardia sinus rhythm, which moved the focus into patient transport and continual monitoring. The patient resolved fine, and it was determined on the follow-up that the patient suffered minor brain damage. Being my first actual CPR, I managed to draw some parallels between uni experience and the actual event. I realized that the procedure in real life is quickly done and compressions are underway within seconds once at a patient. Similarly, in scenario-based practice, CPR is prioritized very quickly. One of the differences I noticed was that the ICP's control of the scene and designation of jobs was unlike uni scenarios because we had no access to ICP, which severely shifts the dynamics of procedures and treatment. In the case of our patient, she was suffering from a cardiac event caused by hypoxic total obstruction of the airway. The treatments used on scene are all based on the current cause for the hypoxic event, in which case was a total airway obstruction. Under treatment, such treatments include CPR, laryngoscope, and intubation and adrenaline. As according to Yatiko and Mehta, upper airway obstruction can rapidly deteriorate the survival rate of the patient. They mention that often a quick physical observation and history will prove helpful to improve the situation. But unlike in our case, the patient was non-responsive and patients were unable to provide an accurate history. The assumption that she had been choking was a calculated risk given the information provided by the ECG indicating that it was a non-cardiogenic cause, and the BVM's failed effect indicated an airway obstruction. This allowed the paramedic on scene to use a laryngoscope to locate and remove the obstruction, proving to be a critical point in the patient's survival, as indicated by the literature. On top, the CPR provided was able to continue minimal blood flow, which has been proven by Berwick and Mayer to prevent the hypoxic effect on living tissue, including brain tissue, preventing further damage and adding to the benefit of the patient's survival, considering she only received minor brain damage. Furthermore, the adrenaline administration given by the ICP supports Callaway's research that adrenaline is majorly beneficial in short-term return of pulse, which has a primary effect on perfusing coronary arteries and sinuses, in complement to effective CPR. Effective CPR creates the mechanical movement to allow the adrenaline to access adrenergic receptors that will cause ROSC. The intubation of the patient was only placed in once ROSC was established. This direct form of intubation provided adequate oxygen inspiration and expiration to improve perfusion in lungs, ultimately in cooperation with systemic blood flow provided by the heart. At this point, CPR was stopped and transport was prioritized. The intubation in ROSC is supported by the QAS as an effective form of oxygen therapy in recent cardiac arrest. Conclusively, when considering my practice as a paramedic in a cardiac arrest, it is clear that accurate observation and planning can allow a paramedic to identify the cause and adjust treatment accordingly, improving patients' survivability. In this case, it was presented as an upper airway obstruction. Although this event has also made me realize that effective CPR along with proper treatment can lead to improving chances of ROSC, like the outcome of this case. Finally, the post-cardiac arrest management is equally important to maintain and stabilize the patient to ensure you're able to transport and hand over the patient to permanent healthcare management. My first CPR has taught me a lot about planning and observation, effective procedures, specifically CPR, and post-arrest management, which will ultimately make me a more competent paramedic.